You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 22nd, 2025. Our topic is Eosinophilic Esophagitis, presented by Dr. Karen Sue Blatman. She is an assistant professor of medicine and is the program director of Allergy and Immunology Fellowship at Dartmouth and is the section chief in Allergy and Clinical Immunology.
So I'm Karen Sue Blatman. I am the program director and section chief at Dartmouth Hitchcock Medical Center, which is in the middle of New Hampshire. And I've got a couple fellows with me today. Nate and Brenda are also online today. So this is a disease that I've been thinking about since I was a fellow. And I trained at Northwestern, and we worked really closely with the GI group because I think partly because the GI fellows saw a lot of this because we were like surrounded by a lot of restaurants and people would come in with food infections. So that's kind of how I got started. And I've been I see both kids and adults, but I'm medicine trained and then, did allergy fellowship where we see both kids and adults. So that's a little bit of my background and we'll get started. All right, so I don't have any relevant disclosures, but I do have, I will discuss a little bit of off-label use of medications. So my learning objectives are really kind of to talk a little bit about, really just to kind of give a basic talk about eosinophilic esophagitis and thinking about, this is like, I know you'll hear a lot about shared decision making. This is the classic disease related to this because there's not one best choice. All right, so I just wanted to bring up that I will be using shared decision making as a patient-centered approach, and this is something that Dartmouth has been thinking about for a long time, even before we really spent a lot of time talking about this. So I do think that this is something to think about as we, with all patients and treatments and diseases that we see, but in particular, this is something to be thinking about in this particular disease. So eosinophilic esophagitis, the prevalence is about 0.5 to 1,000 persons, and for people who present with dysphagia, it's about 12 to 23% of patients who undergo endoscopy for these symptoms, and it is the most common cause of esophageal food impaction. The dysphagia symptoms are not until you're either a teen or adult, so it certainly presents very differently for kids, but this is the most common reason to be evaluated for. For infants and toddlers, they're going to present with coughing and gagging, feeding difficulties, food refusal, and sometimes failure to thrive. With children, they're going to maybe describe abdominal pain, and they might present with vomiting. And for adolescents and adults, as I mentioned earlier, the most common presentation will be dysphagia. They'll describe some chest pain, they'll describe food impaction, and usually what happens is that by the time you see them, they probably have presented with food impaction, but when you ask them kind of how did they start to think about, when did they start to notice it, they'll start to go back and think about, well, I really started having some intermittent symptoms a few years ago, and over time it has worsened. So what's really interesting is that initially eosinophilic esophagitis, when it was first described in the 1980s, it was really described as a severe form of reflux. And over time, it was then thought to be associated with allergens. And in 1995, there was an important study done at Mount Sinai that looked at when we used elemental formula, patients' symptoms all resolved. And so that was probably the first time that there was some thought that this might be allergen related. And so what I like to take a look at is the fact that there are other people who present with eosinophilic esophagitis present with other allergic comorbidities. So the percentage of patients that present with these is, very commonly we see a huge association with patients who will present with some sort of food allergy. But patients also present with atopic dermatitis and asthma, allergic rhinoconjunctivitis, and it is related to the atopic march. So this is just a nice graph of looking at, again, what we were just talking about, the presentation. And then
why do we care so much about diagnosing and treating eosinophilic esophagitis?
Sorry, say that again.
I think our biggest concern is fibrostenotic complications. As you can see in this slide,
oh, sorry, that's me.
the longer it takes to diagnose it.
All right, sorry about that. I had
typically by the time that.
Oh dear. All right, let me go back. I had done some voiceover for this. So basically, the fibrostenotic complications are the main reason why we. Let me see if I can turn this off. So the fibrostenotic complications are certainly the reason why we get excited about diagnosing patients and helping them figure out a particular treatment. Most of the time, patients who come to us find this, either an annoyance or they're not understanding why it is important for us to make this diagnosis. And our concern is that over time, if it is left untreated, there's a percentage of patients who will have present ultimately with some fibrotic complications. And so there is a time where we can do some, there's a time where we can do reversal with treatment. And so we are eager to have this discussion with patients on why we do the treatments that we do. None of the treatments that we'll be talking about are easy. And so this is the reason why we spend a lot of time explaining to patients that this treatment is important over time. And so the therapy choices, let's see how I can. The therapy choices include diet that we'll be talking about, proton pump inhibitors, swallowed topical steroids, and monoclonal antibody. So initially, the initial treatments, because that it was thought that this was almost a severe version of reflux, in the past, part of the diagnosis guidelines was that you would have to fail proton pump inhibitors to make the diagnosis of eosinophilic esophagitis. We would be taking biopsies and counting the eosinophils in the esophagus, and we would be, for research purposes, they were using the number 15 as the kind of helping diagnose eosinophilic esophagitis, and that is currently what we use in our diagnosis guidelines. We'll go over some of the new guidelines, but subsequently we have found that the proton pump inhibitors are really part of the treatment plan and the initial treatment plan and one of the treatment plans for eosinophilic esophagitis. So it is no longer, failing the proton pump inhibitor is no longer part of the diagnosis. Swallowed topical steroids has also been used, and we're going to go over that. And then most recently there are studies for and FDA approved for a monoclonal antibody. So back in 1995 at Mount Sinai, Kelly and al. Found that patients who went on a elemental diet had a difference of eosinophils in their esophagus. This was a very small study, but it did show proof of concept that elemental diet made a difference in patients with eosinophilic esophagitis, and that was then the start of us thinking about using diet elimination as one of the treatment options. Which foods though? So it's not an IgE-mediated disease, and so skin testing will not pick up these food allergens. And I will use food skin prick testing, mostly to kind of make sure that someone isn't sensitized, so that if we're actually removing the diet and we're removing the food in the diet, having this discussion of whether or not we may actually trigger, or having the avoidance trigger, an IgE-mediated disease is the main reason why I will offer some food skin prick testing. So at Children's Memorial Hospital, now called Northwestern Children's Hospital, Lurie Children's Hospital, they started an empiric 6-food elimination diet. That at that point, the tree nuts and the peanuts were considered a group, and the shellfish and the fish. And so these patients basically went through an empiric diet without using any sort of food testing, and then that's been compared against other foods. There's a 4-food diet, and there's also 2 foods, and there's even a single food, such as using milk. So I like to take a look at there's different ways of using diet for treatment for patients with eosinophilic esophagitis, and we typically like to think of waiting and leaving the most likely allergens for last. So if someone wants to do one food, then often we will talk about either dairy or wheat. If they're interested in doing more foods, then we may choose to do all these different foods, either the 4 foods or the 6 foods, the 8 foods. And I like to think about eliminating, once we finish eliminating it and then getting a scope and seeing the whether the esophagus has responded and that there's no eosinophilia, we'll start to talk with patients about what do you reintroduce back. And so it's a shared decision making. There's going to be certain foods that patients are really eager to be able to add back. There are foods that I'm more concerned about and would like to be able to reintroduce later. And so I would like to put in foods that tend to have a less common trigger first. But for some patients, they may decide that this is a really important element. And I just recently had a patient who has always avoided one of the foods. We ended up doing a 3-food elimination diet, and it turned out that we left his most triggering food as last, and he was right. When he added that food back in, which turned out to be eggs, his eosinophilia came back on his biopsies. And so it's nice to be able to add back other foods in. Even though dairy is a much more common in general, that's still probably more like 60%. So there's a group of patients who do not have dairy as their main trigger. In this particular case, this patient's clinical symptoms kind of match kind of what our results with a scope and biopsies showed us. So this was a study that was done looking at what is different ways of kind of looking at this. So as I noted, in the US, dairy is one of the most common triggers. But if we look at patients in Spain, the literature shows that legumes are a very common reason. Dairy is common, but that fish and legumes are also very common. They're not common in the US. And so there's other studies, such as in Australia, there's some interesting information also from the studies that were coming from these different countries based on the diets of these countries. And then if we take a look at kids versus adults in figure B, it's once again, there's some slight differences when we look at patients. There are a lot more different foods that we see with kids, and with adults, we will see, we still see dairy and wheat as common, but we see more, it's interesting that we see more nuts and legumes with adults compared to children. And then looking at kind of the overall, the figure C is looking at, if we kind of put these all together, the trigger prevalence, these are the most common reasons, these are the most common triggers. And once again, this is where, when we combine all the different studies that we've seen in different countries versus kids and adults, one of the reasons why cow's milk dairy products are one of the first ones to be offered for diet elimination is due to its trigger prevalence. And if we look at the efficacy rates of dietary therapy, we will see that even if we just do dairy, it seems like there is still not a great percentage, but there is a group. So if some people decide that they only want to try one food first, then that might be a great one to try. But you can see that it seems like it's been more effective in pediatric patients than adult patients. There was a time when initially when I was training that we spent a lot of time guiding, having allergy testing guiding. So we would prick to all the different foods and try and decide a diet elimination based off of your specific testing. As I said a little bit earlier, I really use that testing now to kind of figure out if there's a risk for a IgE-mediated reaction if they're already sensitized when you do testing. So I'm really using it more for helping decide reintroduction. And then by far and away, we have the most success with elemental diet, but it is by far the hardest to do and much, much harder to do in adults versus kids. And so there is certainly, the more allergens we take away, the better the better results we have, but then it's a matter of discussing on how do we reintroduce the foods and how do we maintain a diet that is doable and realistic for patients. And these challenges certainly, diets are hard with social events and travel and vacation. It can also, if it turns out that a patient is eliminating a lot of foods from their diet, that we're concerned about nutritional deficiencies, and we're particularly concerned about that with the pediatric population. If a patient is, I have a typo here, but if we are concerned about reintroduction in a risk of IgE-mediated reactions, we may end up doing an in-office food introduction for certain foods. And I think the biggest discussion is that there is not a great way to evaluate. As I said, the testing has been not incredibly helpful for choosing foods for elimination diets, and so for now there are now some non-invasive techniques. We haven't been using them yet at Dartmouth, but there is the concern that people need frequent endoscopies for figuring out which foods and bringing in the food reintroduction. Proton pump inhibitors, there's up to a 50% response rate. And what's in these cases, the proton pump inhibitors is not being used because it is inhibiting acid and reducing acid. It's really being shown to block the Th2 cytokine stimulated eotaxin 3 expression in these patients in their esophageal squamous cells. So we are using the proton pump inhibitors for a different mechanism. And these challenges are often thinking about long-term therapy because it is more difficult to absorb certain nutrients. There's also concern for some renal adverse effects. And I think that it's very hard to be able to adhere to this. The patients have to take this medicine, this medication on an empty stomach. If they forget and they've eaten, then we need to wait a couple hours before we take it again. So a lot of times there's a lot of discussion about adherence with the proton pump inhibitors. But certainly, if that is doable and is efficacious, it is certainly an excellent treatment option for some patients. Then we go to swallow topical steroids, and they are available in these dose packs. They do not have to be refrigerated. It's for patients 11 and older. You do take it twice daily. The most difficult thing probably right now is that it is approved for, the FDA has approved it for 12 weeks maximum use. And so insurance may be the most difficult related to this oral suspension. I think patients like it because they're able to just take it on the go. And this is for patients who either are not interested in doing a food elimination diet, or it's a great option for patients who have been using some sort of treatment, including the diet elimination, and then they're going away for vacation, or there's a time where they just it's the holidays, and they're going to a lot of different parties or different other people's homes or even work-related events, and they're interested, or there's school-based things. This is a great time to be able to use this on an intermittent basis. You can use it for a few weeks and then and use it in specific times to help take a break from the diet. When they looked at, when they did the study, they found that when they compared the placebo patients and the patients with the swallow topical budesonide, that there was very little side effects. I think they certainly had looked at adrenal suppression, and the most common common side effect was respiratory tract infections. There were some patients who did have thrush and fungal infections, and certainly was one of the concerns and side effects of topical steroids. So there's other options for, I think, many years when there was not an FDA-approved option, which just came on very recently. We have been mixing the budesonide in some sort of viscous vehicle. Or people are buying compounded topical steroids or using asthma devices to get that medication. And then in Europe, there's been an approved budesonide tablet, but that has not been approved here in the US. So studies have looked at both fluticasone and budesonide, and looking at this is looking at patients who either at baseline were on placebo, and then as you can see, both patients have both responded to both budesonide and fluticasone. This is a study of about 65 patients who underwent budesonide, and very similar 64 patients that used the fluticasone. And the number one adverse event is candidiasis, thrush. Otherwise, this was well tolerated, and I think that the main thing, the main difference is that this is using any vehicle, and now there's an FDA-approved version of it. So the challenges for steroids is that doing it twice a day, we find that once daily treatments tend to be easier. Twice a day is always harder. And right now, if you don't get the FDA approved version, then you are preparing it at home. You are having to kind of mix it on your own. There used to be a fluticasone inhaler that people would use, and that has since been discontinued. And we talked a little bit about the possible side effects, which include thrush, adrenal suppression, and possibly growth delay, with similar to other topical steroids. And then here's biologics. So this is dupilumab that was approved initially for patients who are 12 and up, and then subsequently have been approved for patients that are 1 and up. And this is results from a phase 3 trial looking at using dupilumab weekly. And this is it's currently FDA approved for weekly doses for patients for eosinophilic esophagitis. And you can see that there is definitely, there has been an improvement percentage of people who not only had histologic remission, but also in change in the quality of life scores. There have been previous studies in other biologics looking at like anti-IL-5s, and what was interesting in those patients is that they had histologic remission, but they did not have symptom relief, and so those biologics were not approved for treatment for eosinophilic esophagitis. And so there is pediatric dosing. There's pediatric dosing for the dupilumab. And so when sorry about this. In terms of the treatment summary, if we look at this histologic remission rates, their elemental diet is by far the best, but by far the hardest to achieve and be compliant for a long time. It's great to probably use it as an initial decreasing inflammation, but it is very difficult to continue. And then we look at proton pump inhibitors, which are about 50%, and then looking at elimination diets and swallowed topical steroids and dupilumab, they all are very similar in efficacy. So the current guidelines with the American College of Gastroenterology is, once these are these were published in January of this year, is that we look at diagnosing eosinophilic esophagitis. We try and the goal is to, as I said, is to treat that inflammation and assess for fibrostenosis in all these patients. Then we talk about, I like to start with an anti-inflammatory treatment, and then we talk about whether or not we really focus on diet or we focus on medication. And then essentially both ways are anti-inflammatory. If we choose medication, then we are going to talk about whether we start with a PPI or topical steroids. And then within the topical steroids, do we try for Ohelia, the FDA-approved product, or trying to use it using either fluticasone or budesonide off-label? If we choose to go to diet, then we talk about what type of elimination. Do we do one food? Do we do a bunch of foods? So that's a lot of discussion. And then we will, whatever we do, I usually do 8 to 12 weeks of that treatment, and then we assess response and look for remission, or we look for, any sort of fibrostenosis with using endoscopy. If there is not a response or there's difficulty with adherence, we then talk about either changing one of the treatments or including the discussion with biologics. And then once again, I typically are using 8 to 12 weeks of treatment and then looking for response. The Joint Task Force has also weighed in and looking at the dupilumab and who are the best patients. And so if if we wanted to consider that first line, this is not something that, as you saw, the ACG, the American College of Gastroenterology, is not putting dupilumab as that first line. They're considering the other choices, other treatment plans as first line. And then, but in our case, I think it is true that if some patients have multiple atopic conditions, they have asthma, they have atopic dermatitis, they may be a great candidate for using dupilumab as a first line treatment to take care of all of these comorbid, the eosinophilic esophagitis and the comorbid atopic conditions. If there's a strong preference for patients to either avoid diet elimination or they are not interested in topical steroids, that's also a consideration. And then it's with these patients who have the atopic conditions of either moderate, persistent, difficult to treat asthma or atopic dermatitis, or patients with chronic sinusitis with nasal polyps, they are great candidates for eosinophilic esophagitis treatment. What is different is both asthma, atopic dermatitis, and chronic rhinosinusitis, those dosings are all every 14 days compared to eosinophilic esophagitis treatment, which is every 7 days. And then the context when we think about step-up therapy is the difficult to treat eosinophilic esophagitis, people who have patients with failure to thrive, poor growth, significant weight loss, and then frequent use of rescue therapies. They're requiring systemic steroids, they're requiring multiple dilations, if they're having a severe diet restriction, or they're requiring elemental diets. If someone is particularly having difficulty getting, they're very narrow, they're having trouble with getting a scope down, we would be considering those patients who are really on that spectrum of showing a lot of fibrostenotic disease, or they're refractory or have adverse events to current therapy, the current therapy that they have. Joy Chang did this nice study on kind of taking a look at the patient's barriers to different treatments, and for looking at the topical steroids, patients may be concerned about side effects. Patients or parents mostly are concerned about the side effects of taking steroids. For adults, they're thinking about the financial costs of different medications. There are patients who would prefer not using medication, and the inconvenience of taking something every day. For diet, at least for some kids and parents, they might be concerned about a restrictive diet. That seems to be a bigger issue with adults versus kids. And the biggest thing is the inconvenience of multiple endoscopies for reintroduction. And then thinking about the quality of life or concern for inadequate nutrition for kids. And then thinking about when there is a restrictive diet, that it can be costly. There can be a financial barrier to being on a diet elimination. And then for patients who are thinking about whether they need a dilation because of the concern of a narrow caliber esophagus, thinking about dilation being a high-risk procedure. Parents are more concerned about that for the kids, but they're also thinking about discomfort, endoscopy, and dilation, the financial costs for that, and the inconvenience of having a procedure, or for adults, having to have someone come pick them up, just kind of the logistics of having a procedure. And then for some people, the symptoms are just not bad enough to need the treatment. So our role is to help treat the atopic conditions and helping interpret the allergy tests. One thing that I didn't really talk about today was that patients with eosinophilic esophagitis often have pollen food allergy syndrome symptoms as well, and some of those will be cross-reactive to the environmental allergens. We are really great about helping discuss the consequences of food elimination and the potential for a new IgE-mediated allergy if we are removing these during a diet, and then helping guide people through either medication or diet therapy. All right. Any questions?